Moving on to Chapter 9, Pain. People living with some form of pain is much more widespread than you may realize. I would even consider some of these figures as possibly low. Your textbook states that up to 25 million people experience acute pain from injury or surgery every day. Chronic pain affects over a million American adults. And chronic pain is a major symptom from everything from patients with cancer, arthritis, previous injuries, whether neurological pain, and many other forms that we're going to be getting into in this module. Pain is a complex, multidimensional experience that's closely related to suffering and a decreased quality of life. And unfortunately, it's also a subjective symptom. Remember back to our previous chapters where we talked about the difference between objective versus subjective pain. Objective symptom would be something we could see, something we should measure. But at the same time, subjective is something we have to take our patient's word about. And when your patient tells you they're in pain, we should believe them, because they are the only ones that are able to judge their pain. And that pain threshold and how they manage pain can vary wildly from patient to patient. What may be a debilitating injury to one is very easily managed by another. It's a very subjective experience that we should always take serious. There can be many negative consequences of untreated pain. Everything from unnecessary suffering, physical and psychosocial dysfunction, immunosuppression, sleep disturbances, and just that decrease in quality of life, irritability that goes along with constantly managing pain while living your day-to-day life. Pain, again, is subjective. It is always what the patient says it is. Nonverbal. Are they screaming? Are they agitated? Are they wincing? Are they looking like they're guarding a certain area? All of these could be signs that patients are in serious pain, even if they're unable to report it themselves. There are many different aspects of your patient that could be affected by pain. The biopsychosocial model of pain states there's physiologic impacts, affective, meaning mood impacts, cognitive impacts, behavioral and sociocultural impacts, and all of these can combine together. It's not that the pain is necessarily only affecting one area. It's that pain is affecting that patient in a wide variety of these areas, and it's all combining together to create a negative experience for your patient. Nociception. This is the physiologic process by which we communicate information about tissue damage to the CNS, and it involves four processes: transduction, transmission, perception, and modulation. A good example of this would be I put my hand on the stove. That tissue on my hand is now being damaged. That is that transduction. It knows that damage is occurring, and it sends that signal up the central nervous system to the brain, where that is then perceived as pain. And from there, modulation, the body's instinct to respond and pull their hand back away from the stove. That transduction occurs when there is a release of chemical mediators. Moving on to the transmission, this involves that conduction of that action potential from the peripheral nervous system up to the central nervous system through the spinal cord to the brainstem, thalamus, and cerebral cortex. Then you got that perception where your consciousness is aware that there is pain and damage going on. And finally, modulation involves signals from the brain going back to the spinal cord to lessen that painful impulse. Transduction occurs through a conversion process of a noxious mechanical, thermal, or chemical stimuli. It's then converted into that neuronal action potential, and it can be transmitted through the nervous system. This noxious or damaging stimuli causes the release of a wide range of chemicals, everything from substance P and adenosine triphosphate, ATP, or other chemicals such as serotonin, histamine, prostaglandins, and these are all released depending on the type of injury being sustained. Inflammation is another process you'll see coinciding with injury, and there's many reasons that this inflammation occurs. And primarily in our initial pain, it's going to be that peripheral sensitization. It's firing nociceptors in response to a stimuli that previously were insufficient to elicit a response to that non-painful stimuli. Nociceptive pain is from activation of these peripheral nociceptors. There are a wide range of therapies that we can use to help lessen this patient's pain. Everything from meditation, guided imagery, up to the obvious pharmacologicals, which one of your first courses is going to be NSAIDs. These are non-steroidal anti-inflammatory drugs, and these help lessen that inflammation to help lessen the pain from that injury. Transmission, that is that process by which we relay pain signals from the periphery to the spinal cord and then to the brain. A delta fibers conduct pain rapidly, and they're responsible for that initial sharp pain that accompanies the tissue injury. The C fibers, on the other hand, transmit that painful stimuli more slowly. They produce pain that is typically aching or throbbing. There are three segments involved in this process. There's that transmission along the peripheral nerve fibers to the spinal cord, up through the spinal cord to the dorsal horn processing, and finally that transmission to the thalamus and cerebral cortex. During the transmission along the peripheral nerve fibers, first-order neuron extends from the periphery to that dorsal horn and can only be blocked by a sodium channel inhibitor or a lesion. Dorsal horn processing involves the neurotransmitters produced during activation or inhibit the activation of those nearby cells. Exogenous or endogenous opioids bind to the opioid receptors, blocking the release of neurotransmitters. And these produce an analgesic effect, similar to morphine or some sort of opioid that we would give our patient to induce the same pain-relieving effects. And finally, central sensitization. This occurs through increased sensitivity and the hyperexcitability of neurons within that central nervous system. Allodynia, the normal sensory input, causes abnormal sensing and responses to painful and other stimuli. Wind-up. This occurs with ongoing stimulation of slow-conducting unmyelinated C fiber nociceptors. It involves the firing of specialized dorsal horn neurons as it gradually increases. It can lead to sprouting of a wide dynamic range of neuron dendrites. And this results in an increased capacity to transmit a broader range of stimuli-producing signals. Neuroplasticity. This is a process that allows neurons within the brain to compensate for an injury and adjust their responses to new situations or change in their environment. Referred pain may occur with that injury or disease involving visceral organs. The location of a stimulus may be distant from the pain location reported by the client. It's not necessarily that pain is felt in the exact place of the injury. Going deeper within the nervous system, finally that transmission to the thalamus and cerebral cortex involves fibers of the dorsal horn as they enter the brain via the spinothalamic tract or the spinoreticcular tract. And thalamic nuclei have projected into cerebral cortex, and it's this area of the brain where opioids work, and it's this part of the central nervous system where those opioids that we're giving our patient have their effect to lessen that pain. Pain. This occurs when pain is recognized, defined, and assigned a meaning. In the brain, nociceptive input is perceived as pain. There's no single precise location where pain perception occurs. It's a multitude of areas all working together in tandem. And that cortical structures are crucial to constructing the meaning of the pain and helping your mind make sense of the sensations it's receiving. Finally, modulation. This is your body reacting to that painful stimuli, involving an activation of descending pathways, and can occur at a level of the periphery, spinal cord, brainstem, or cerebral cortex. There's multiple ways to classify pain. The first is going to be on where it originates. That nociceptive pain we've been talking about originates from the site of an injury. I bang my finger with a hammer. It hurts. That is a nociceptive pain. Not to be confused with a neuropathic pain, which may occur in the absence of an injury. These are misfiring neurons within the body sending out painful stimuli when there isn't necessarily any injury. Another way we could classify pain is by duration. And again, that acute versus chronic that we talked about last week. Another way we could classify pain would be by somatic versus visceral. A somatic pain would be to think of external, along the skin, muscles, or connective tissue, versus that visceral tissue, visceral pain, and that would be more blood vessels, organs, and internal damage within the body. And they could be everything from surgical incisions, broken bones, arthritis, and this type of pain is usually responsive to opioids and non-opioid medications. Another, even further deeper differentiation would be superficial versus deep. A superficial injury, a superficial somatic pain, arises from the skin, mucous membranes, anything on that farthest outer layers of the body. And then deep somatic pain arrives from bone, joint, muscle, skin, connective tissue, and described as aching, throbbing. Then visceral pain. This is damage to those internal organs. And it involves the activation of nociceptors within the lining of those body cavities. Response to inflammation, stretching, ischemia, stretching from tumor or obstruction, involving the intestines, bladder, heart, lungs, any internal organ. And another common variety would be neuropathic pain. And this is damage to those peripheral nerves or central nervous system. And these damaged nerves are sending out signals of pain constantly, even if there's not necessarily a current injury occurring. Often described as numbing, hot, burning, shooting, stabbing, or electric shock-like. And they can often come and go. It's not necessarily one constant pain. They could have periods of remission and periods of exacerbation, and described as sudden, tense, short-lived, or lingering. Deafferentiation. This is a loss of or altered input, altered stimuli, and it's going to come and go. Another term to be aware of in here would be allodynia. This is the term for a stimuli that's not normally painful now causes great pain to that patient. Just lightly brushing against a normal healthy hand would not necessarily cause pain. For a patient with neuropathy, just lightly brushing against it could cause a stimuli to that altered nervous system, sending out serious pain signals. Peripherally generated neuropathic pain. These are painful polyneuropathies felt along the distribution of many of the peripheral nerves. And painful mononeuropathies. These are associated with a known peripheral nerve injury. We know exactly which nerve is injured and exactly which nerve is sending out those abnormal signals. And finally, complex regional pain syndrome, CRPS. And this triggers tissue injury, surgery, or vascular events. We have widespread neuropathy, widespread neural damage. Neuropathies are treated with a multimodal approach. A lot of different combination of analgesics, tricyclic antidepressants, SNRIs, anti-seizure medications, transdermal lidocaine. Those lidocaine patches are very effective, very commonly used. And there is one key thing you need to be aware of, comes up a lot on NCLEX, and that is that those are only worn for 12 hours at a time. So often you're going to put that lidocaine patch on at 7 a.m. when they get up, and then you're also going to take it off again at 7 p.m., maybe 9 to 9, varying depending on the patient's sleep schedule. Acute and chronic pain, those treatments are going to be based on the differences, depending on the cause, the course of the pain, the manifestation and the symptoms, how severe, is it aching, dull, sharp, stabbing? As we talked about in that previous chapter, acute pain has a sudden onset, lasting less than 3 months' time, maybe mild to severe, and usually a precipitating event or illness can be identified as the cause of this acute pain. On the positive side, acute pain has a limited duration. The course of the pain decreases over time and eventually goes away as the pain recovers. It includes postoperative pain, labor, traumas, and the treatment goal is pain control with the ability to take part in recovery activities. Are we ever going to get the levels of pain down to zero? In some patients, unfortunately, that is not possible. But we do want to make sure we're at least trying to get that down to a manageable level for that patient. While pain is always subjective, there are objective symptoms we could be observing, especially in the case of acute pain. Everything from increased heart rate, increased respiratory rate, increased blood pressure, diaphoresis, pallor. Chronic pain, on the other hand, this is pain that does not go away, lasting longer than 3 months. May start out as acute pain, but gradually changes over time to become that chronic pain that the patient is now living with long term. And again, could be everything from mild to severe, with a known cause or unknown cause. This chronic pain could also have its own objective symptoms we could be observing. Decreased physical activity, fatigue, as that constant pain is constantly wearing that patient down. They'll eventually withdraw from others as they attempt to deal and manage the weight of this chronic pain that they're carrying. Chronic pain can be disabling. It can be debilitating, extremely difficult to live with. and often accompanied by psychosocial issues such as anxiety and depression. The treatment goal is to control this pain as much as possible, to bring that pain level down to something the patient can manage to improve their quality of life. Pain should be screened for in all patients, especially in the case of that long-term chronic pain. The patient may not come out as a chief complaint, may not report it as anything out of the usual because they have grown accustomed to living with that pain, but it should be screened for in all patients. When assessing pain, there's two different mnemonics you could use, OPQRST or OLG-CARTS. I'm a big fan of OPQRST. I feel like it just rolls a little better. Both measure the same thing. In the case of OPQRST, that is onset, when did the pain begin? P, provocation, does anything make that pain better or worse? Q, quality, describe that pain in your own words. Dull, aching, throbbing, sharp, stabbing. R, radiating, is the pain radiating anywhere? Especially in the case of a myocardial infarction. It has very common areas such as the jaw or left arm where it radiates to. Severity, that is on a scale of 1 to 10. And finally, time. How many times has this happened? Does this happen frequently, constantly, sporadically, very rarely? And we're going to use a lot of different methods to differentiate and assess this pain and its cause. Everything from that direct interview, because again, pain is always subjective. Observing that patient for discomfort, diagnostic studies, and physical assessment to identify any injuries that even the patient may not be aware of. Documentation is critical to ensure that safe, effective communication. And again, I would go ahead and write OPQRST down right now. Onset, provocation, quality, radiating, severity, and time. That's one mnemonic I probably used every single day while working the floor. Pain onset, it may be identifiable or it may be unidentifiable, especially in the case of a long-term chronic pain. After a while, the patient may not even remember when it began or remember how it began just because it's slow, insidious buildup. And the pain may be constant, intermittent. There's so many different varieties of pain. You want to document that in the patient's own words. Obviously, the location is going to be a key aspect that we document. We want to know exactly where is that pain occurring. Is it radiating? Is it spread out? And keep in mind that where that patient reports pain is not necessarily where the injury is occurring, but it is that first step to identifying the underlying issue. Breakthrough pain. This occurs in patients with chronic stable pain. And as we said, it is not one constant pain level. We may be able to manage their everyday chronic pain, but they will get breakthrough pain because it is having periods of exacerbation followed by periods of remission. Areas of referred pain here on figure 8.3, and this just gives you a general idea of where certain internal visceral pain could be radiating to on the external parts of the body. When documenting the intensity of the pain, that 0 to 10 scale is going to be your first go-to, your most commonly used. 0 being no pain, 10 being the worst pain you've ever felt in your life. There could also be verbal descriptor scales and visual pain scales for nonverbal patients or very young children. Quality. Again, how does that patient describes the pain in their own words? Burning, numbing, shooting, stabbing, sharp, aching, throbbing, dull, cramping. The associated symptoms of pain may worsen or be worsened. Anxiety, fatigue, depression, poor sleep, and as we covered in the previous chapter, just the negative effects that poor sleep can have on a person's quality of life. There's many different strategies we can employ, everything from prescription and non-prescriptive drugs. Non-drug therapies, hot and cold applications, complementary and alternative therapies, relaxation therapies, guided imagery. It's not necessarily just give them a pill. It's not necessarily pharmacologic intervention is our first and only method to help control this. Pain has serious impacts on the patient, as we've covered. We really want to assess the effect of pain on their quality of life, their ability to sleep, interact with others, on their mood, and really talk to the patient, have them open up and figure out exactly how negatively this is impacting them and to what level they would be able to manage with. Because unfortunately, we may never be able to get it to 0, but we can at least bring that level of pain down. Make sure you're reassessing that pain frequently as well. Everything from severity, the physical and psychosocial condition, and make sure you're following up documenting that as well. Also, you give your patient Tylenol, you need to come back, reassess that patient's pain. We need to know whether that intervention was effective, what effect it had. Follow the principles of pain assessment, OPQRST. Keep in mind it is always subjective, that pain is whatever they say it is. Base the treatment plan on the patient's goals, what they would like to see happen. Maybe this patient does indicate serious high-level doses of opioids, but at the same time that patient does not want to take that much, does not want that negative sedation. We really want to treat that pain at a level that fits with that each individual patient. And again, it is not necessarily just one method of treatment we're using. It needs to be a combination, both drug along with relaxation. Using an analgesic along with a hot or cold therapy. We want to try a multitude of interventions together to both find which one is most effective and to maximize the effectiveness of all of those interventions. And again, we want to constantly reassess this patient's pain. We do any intervention, we want to make sure we're assessing that pain afterwards as well. We want to see how effective it was. If it did not have any effect, we need to find a different intervention and try a different route. There's 3 categories of pain medication: non-opioids such as NSAIDs, opioids, and adjuvant drugs. That's as we talked about for a patient using SSRIs to help increase the effectiveness of our other analgesic medications. Non-opioids: acetaminophen, aspirin, NSAIDs. These do not produce tolerance or physical dependence. Many are over-the-counter and often used in conjunction with opioids. I do want to preface this as be very careful. Acetaminophen, NSAIDs, these are drugs themselves. They can have negative effects. I remember being in the Army and seeing people take large doses of NSAIDs all the time, every day. That is a seriously nephrotoxic drug. The same thing with acetaminophen. People will have chronic pain and they will gradually take more Tylenol, thinking it is this benign drug. And it really is not. It has very hepatotoxic. It is damaging to the liver. You really want to be very careful because unfortunately patients look at these over-the-counter analgesics as benign when they can be extremely harmful when not used properly. Aspirin's effective for mild pain. Use is limited due to the bleeding side effects, especially GI bleeds. Some NSAIDs may have better efficacy. Side effects include GI problems, renal insufficiency, and hypertension. Another non-opioid, acetaminophen, Tylenol. It has analgesic and antipyretic effects, meaning we could both use it for pain, but we could also use it to lower a fever. It also doesn't go along with the antiplatelet properties that, say, an aspirin would have. It does have that potential for hepatotoxicity. There are a lot of cases of liver failure out there of people that misuse Tylenol. And finally, NSAIDs. Ibuprofen, naproxen. These are anti-inflammatory analgesics. They both lower inflammation, but they also have those analgesic, pain-lowering properties. And a very hot-button issue here in the Midwest, opioids. These bind to receptors within the CNS. They're a very old drug, and they're a very effective drug. Unfortunately, they can also lead to very serious addictions. It is a pure agonist. It binds to those opioid receptors within the body. Morphine, oxycodone, codeine. It's potent, no analgesic ceiling, and has several routes for administration. Effective for moderate to severe pain. And keep in mind, always be assessing the respiratory rate of these opioids. Because how do opioids kill? Primarily it's by respiratory depression. You may also see it combined with non-opioids for moderate pain. That acetaminophen with codeine, hydrocodone plus acetaminophen or ibuprofen. Adding acetaminophen limits the total daily dose. We're using multiple different analgesics within one pill. And methadone. This is a controversial one. This is a drug that's also used for opioid withdrawals, primarily used in the treatment of chronic pain, may cause respiratory depression, cardiac toxicity. You'll hear methadone come up a lot, often in a negative connotation, but it is a very effective pain reliever in its own right. And we could also have a class called mixed agonist-antagonists, such as butorphanol, that helps to both stimulate as well as block those pain receptors simultaneously. There's also dual mechanism agents. Tramadol is going to be a big one. It's a weak mu agonist and also inhibits the reuptake of norepinephrine and serotonin. Back when I was working dual diagnosis, this is one of those synthetic opioids that we would actually give the patients to help manage their opioid withdrawal. You'll see a lot of crossover in that area as well, and that pains that are used to manage pain, stimulate those opioid systems, are also used to help wean the patient from much stronger opioids. Common side effects of opioids, constipation is going to be a big one. Actually getting into that opioid withdrawal, working in dual diagnosis, that first stool, once they get off of opioids, can be massive. Also very relieving for the patient. Fortunately, they'll be very proud of it in some cases. Also, common side effects of opioids, nausea, vomiting, sedation. That respiratory depression is going to be your priority assessment. Anytime you're given an opioid, you need to very carefully document both that respiratory rate and continue to document and assess that respiratory rate afterwards. Opioids also have a tendency to build a tolerance, and that they need more and more and more for the same desired effect. Again, that opioid-induced respiratory depression, I cannot stress enough how important it is, both in real life as well as once you get on NCLEX, to really be, as soon as you see an opioid, be thinking respiratory depression. In the cases of opioid-naive patients, patients with very little tolerance to opioids, they have a much greater risk of respiratory depression. But that's not to say the same effect can't occur with a patient who takes them much more frequently as well. Also, itchings, most common with epidural or intracatheteral routes, and some patients get very itchy on opioids. Those adjuvant therapies we talked about, such as SSRIs, mood stabilizers, anti-seizure medications. There's a lot of different medications out there that can also have analgesic effects. And while they weren't necessarily designed and intended for pain control, they do have some pain controlling effects that we're using them for. Drugs we're going to get into a lot much more deeply in our mental health course. Tricyclic antidepressants, SNRIs, anti-seizure medications, which not only used for seizures, they're used for pain, but they're also used as mood stabilizer in mental health field. Other things such as corticosteroids, steroids to lessen that inflammation, very effective in the case of arthritis. Local anesthetics, and cannabinoids. When scheduling out our medication schedule, we want to focus on prevention, not control. We don't want to wait till that pain's at its peak. As soon as that patient starts to feel some pain, they should be taking their pain-controlling medications. It's going to be much more effective if we catch that early, before that pain is built to a high level. Then it's going to take much more medication, be much harder to bring back down. And titration, adjusting that dose based on the patient's assessment. We don't just want to go to the highest dose every single time. At the same time, we don't want to go to the smallest dose, because that won't necessarily be effective. We don't want to give that patient too much pain medication, obviously, but we really want to prioritize controlling that pain as well. Another term you may hear would be equianalgesic dosing. And this is a way to compare the effects of two different drugs. In this case, a dose of one analgesic that's approximately equivalent to the pain-relieving effects compared to another analgesic. And it gives you a general sense of measurement and a way to compare the effects of two different classes of medication. Another thing to be aware of is the different routes of analgesic medication. Whereas a PO pill may take longer to take effect, may be slower to initiate and get the effects, it may also last much longer. Whereas an IV medication will take that very rapid onset, but it could also last for a much more limited amount of time. And it really is finding that right route in the intended effect we're seeking. If there's patients in severe pain, we don't want to give them a pill. We want to give them IV or IM if at all possible. Whereas if we're talking about chronic pain, we're expecting pain to be occurring down the road, we may go for a pill, which is going to prevent that pain from occurring, but will also last much longer throughout the day. It would also be a route that they could take at home versus a more acute case of IV. Obviously, oral PO medication is that route of choice, functioning within the GI system, and the doses can be larger due to that first pass effect, meaning that some of that medication is pulled out of the bloodstream before it has a chance to take effect and be distributed. Other routes are going to be transmucosal and buccal. These would be medications dissolved on the buccal cheek or transmucosal underneath sublingual. Fentanyl lozenges on a stick, cannabinoid extract sprays. Other options could even be intranasal, meaning nasal sprays, or rectal, such as opioid suppositories. Another route would be the case of intraspinal delivery. This is used a lot in the case of labor and delivery, epidural space, subarachnoid space, intermittent boluses, or continuous infusion, delivered close to the receptors within that dorsal horn of the central nervous system. Unfortunately, complications include catheter displacement, migration, accidental infusions, and even infection. Another route to be aware of that you as LPNs are probably already aware of are the importance of those fentanyl patches. They give slow, continuous doses of fentanyl throughout the day, very, very effective at dealing with that long-term chronic pain. Another thing to be aware of is make sure you are very closely documenting that patch. As soon as you come on, make sure you're putting eyes on that patch before you sign for that patch. And then you're making sure when it's time to take it off, you physically take that patch off and see it disposed of properly. They are very highly sought after by drug-seeking family members. They will actually be able to open that thing up and take the fentanyl out of it. Other things, parenteral routes, subcutaneous, IV. We talked about that, intraspinals, and patient-controlled analgesia, PCA pumps. This is one we'd use a lot in organ transplant. The incisions for a liver transplant is a chevron across the abdomen. It's a very large incision. It's a very painful incision. And these patients would actually have that PCA pump where they got the button right there in their bed. And we can set it so that they can get so many doses per hour, so many doses per minute, however you want to set it. And we can control it, but they can also have immediate control of their own pain. So when they feel pain, they hit that button. Unfortunately, you as a nurse can also see exactly how many times they've hit the button. Every now and then you'll come in and see the patient has hardly hit it. It's time to start, we can start talking to the doc, get this thing discontinued. You'll go in there and see other patients that have been playing that thing like a video game. He's hit it 500 times an hour. It is only going to hit as many doses as it's set for. Implantable pumps. These are intraspinal catheters that may be surgically placed for long-term pain relief. The catheter is connected to a subcutaneous pump with a reservoir, and it's programmable set at a fixed rate, meaning it can be set to slowly infuse over time. Those PCA pumps, a dose of the opioid is delivered every time the patient decides the dose is needed, and they hit that button. And it delivers what's called a bolus. There's also that basal rate administration, or a continuous rate. And teach the patients that they cannot overdose. We're going to be making sure that you're monitoring this patient very closely. Anytime they're getting an opioid, that respiratory depression is a serious, serious consideration. Also, never give an opioid while a patient is sleeping. If they have that scheduled, do not give that opioid while that patient is asleep. Make sure they have woken up, you've assessed them. You want to be very careful. You really do want to look out. There's actually a very serious situation at Mount Carmel in Columbus, Ohio. If you wanted to look further into that one, some nurses were really fighting with their license for a long time due to the dosages of fentanyl being given to hospice patients. The doctor, I believe, they were really trying to put him in jail for a long time, and I don't even believe it was malicious. He wasn't even giving overdoses. He was giving patients the maximum allowed doses, and I feel like he was just a younger doctor trying to treat these patients' pain, had some pity on these hospice patients. And unfortunately, some of them died, and it was attributed to those opioids. And it created a lot of problem both for that doctor as well as the nurses involved, who were giving medications right within parameters and still got involved with that. Opioids are a very, very hot button issue. They're very necessary. They're very effective at controlling pain. but it's also something you should be very, very aware of when you're working with them. Another therapy to be aware of would be therapeutic nerve blocks. These are local anesthetics infused into an area, such as lidocaine patches we talked about earlier. And they help interrupt those different transmissions, not even necessarily only nociceptive input. And it's used during and after surgeries is a very common time to manage that pain. Also could be used in the form of continuous infusions for chronic pain. Other interventions would be neuroablative techniques, and this is used to destroy the nerves to stop that pain transmission, such as surgical resections, thermocoagulation, and it's used for severe pain that's unresponsive to other therapies. Not to be confused with neuroaugmentation, and this is electrical stimulation of the brain and spinal cord, commonly used for chronic back pain. And just an example here on our screen, got a diagram of some of those sites of neurosurgical procedures. While drugs are very, very effective, non-drug therapy can be extremely effective as well and should always be considered. Reduce those doses of analgesics as needed to help minimize those side effects. Increase the patient's sense of personal control. Possibly alters the ascending nociceptive input or stimulates descending pain modulation. It's useful for both acute and chronic pain. It's not necessarily one intervention we're using. A combination of different treatments can often be the most effective. Non-drug therapies, massage, exercise, those TENS procedures you're hearing more and more about, that's transcutaneous electrical nerve stimulation. We're actually sending an electrical signal up through that nervous system so that it cannot transmit the pain. Other ones, acupuncture and heat and cold therapy, can also be very effective. Just a diagram here on slide 87 showing you how a TENS procedure works, where they would stick those electrical electrodes on either end and run a signal through those nerves to block the transmission of pain. Many patients also report success with cognitive therapies. Distraction, hypnosis, relaxation, guided imagery was a big push at the Cleveland Clinic many years ago. Effective communication is going to be key. Pain is subjective. I cannot say that enough in this module. And we always believe the patient when they say they're in pain. The patient's report of pain is believed. It is not perceived as complaining. Our instinct may be that they're complaining, but at the same time, we always want to believe any patient when they say they're in pain. Because what if we're wrong and we are leaving a patient suffering in pain when we could have done something to treat it? The nurse should also communicate concern, commit to helping other patients, show empathy, empathize. That both acute and chronic pain can be debilitating. And even if they're not necessarily showing objective symptoms, they could be really feeling it. Challenges to effective pain management? As we've said, tolerance. Patients can build a tolerance to especially opioids very, very quickly. And that creates a major risk, ties right in with the physical dependence and addiction, which opioid withdrawal and opioid addiction is no joke either. They say a lot of the heroin epidemic was fueled by oxycodone. A lot of people that are addicted to opioids began by taking something their doctor gave them. And then when they were no longer getting the same effect, they went to street drugs. Tolerance, by definition, is the need for increased opioid doses to maintain the same degree of pain control. They need more and more and more to get that desired effect. One way we can lessen this is through opioid rotation, and that's switching from one opioid to another to help slow the development of that tolerance. Another major concern with that increasing dose is they could get what's called opioid-induced hyperalgesia, where those higher doses of opioids actually increase the sensations of pain, having a paroxysmal effect. Physical dependence to opioids is a concern that can't be overstated. It's that normal physiologic response to ongoing exposure to that drug to the point where that body is physically dependent on it. And unfortunately, opioid withdrawal is no joke. Working in dual diagnosis, working with these patients, it looks a lot like the flu from our perspective. Very sweaty, achy. They just look miserable, nausea, vomiting. And you really want to do everything you can to both assess this patient while they're going through it and to do everything we can to lessen those symptoms. Another term to be aware of would be a pseudo-addiction, where these patients aren't quite physically dependent on it, but that addiction is growing. The other thing could be a think about with the difference between a psychological addiction versus a physical addiction. And this occurs when patients show behaviors associated with addiction, but the behaviors resolve with adequate treatment of the patient's pain. Addiction is a neurobiologic condition with a drive to obtain and take substances other than those prescribed for therapeutic value. Tolerance and physical dependence are not indicators of addiction. The hallmarks of addiction are that compulsive use, loss of control, and continued use despite risk of harm. Think about a patient comes in, detoxes off of opioids. Their body has been clear of opioids for 30 days. They get out and they feel a compulsion to use again. They're not physically dependent anymore. They have not had that substance for 30 days. They are not feeling physical withdrawal symptoms. But that psychological addiction, that drive, they'll get out and relapse. As with any drug, gerontologic considerations are going to be a major concern here. Persistent pain is a very common problem associated with the elderly, physical disabilities, long-term chronic issues, arthritis. 50 to 80% of older adults are estimated to have chronic pain problems, and these patients will be very frequently on opioid medication for a long, long time, because that is what is effective. That is what treats their pain. At a certain point of how long are they addicted versus their age and the stress of withdrawing should they become seriously addicted, there's major, major considerations that come into play with the elderly of just how effective those opioids are versus the very real dangers as well. The most common painful conditions of the elderly are usually musculoskeletal, arthritis, lower back pain, knee pain, the buildup of injuries, the wearing out of those cartilage cushions between the bones, and often many of them are living with pain for a very, very long time. Living with this chronic pain, as we've said previously, leads to depression, sleep problems, decreased mobility, increased healthcare use, physical and social role dysfunction. It can be extremely debilitating living with this chronic pain, especially depending on the level of the pain, the location of the pain, and how well that patient is able to manage their own pain. Because again, it is subjective. Two patients with the exact same injury, one could manage the pain from that very well, while another would find that pain completely debilitating. It really is patient dependent, and we always believe their reports of pain and how they're managing it. Treatment cautions with the elderly: they metabolize drugs much more slowly. They have a greater risk of GI bleeding with NSAIDs. Multiple drug use can lead to drug interactions, cognitive impairment, and even worsening ataxia and neurological disturbances as well. There's many barriers to these patients seeking treatment for that pain that they're living with. Everything from the belief that that pain is inevitable, a normal part of aging, fear that they're being a burden or just complaining, fear of using opioids. It is a very, very hot button issue, and it's going to be a very hot button issue for a long, long time. Using words like aching, soreness, or discomfort instead of pain. And there's a high prevalence of cognitive and sensory perceptual motor problems that go along with the elderly as well. Think of other special populations that are just unable to self-report their pain, whether they're nonverbal, language barriers, children that are very young. And in that case, we're going to be observing that patient's facial expression, their breathing, their body movements. Are they guarding a certain area? Do they seem like they're in pain when they move, when they get up? You really want to be watching closely because we don't want to leave any patient in pain. Other patients at a higher risk for pain have medical conditions such as ischemic, infectious, or inflammatory processes, are immobilized, have invasive monitoring devices, have undergone procedures. There can be a large range of issues and causes that could cause that pain. But again, not to sound like a broken record, it is always subjective. We always believe our patient. And we use every tool at our disposal to help treat it. And wrapping up with substance use problems. Assessing and providing relief with a dual diagnosis of pain and substance use are challenging. These patients still have a right to receive effective pain management. They still have a right to have that pain managed, to be treated somehow. It's very sad that they have now become addicted, dependent on those opioids. And we really need to do everything to be aware of that addiction, but we also really need to be helping these patients manage their pain as well. And it can be a dual-edged sword, a very difficult balancing act to manage. We want to be closely assessing these patients with a detailed history, a physical examination, diagnostic workups. We want to gather all the information at our disposal to be able to make an informed decision about how to properly proceed with this patient in a way that's the best option. Minimize risks, but still treating that pain, because we don't want to leave any patient to suffer. And finally, establish that treatment plan that will relieve that pain, minimize withdrawal symptoms. And this is going to take an interprofessional team approach. You're going to have pain management specialists involved. You're going to have dietitians involved monitoring for the nutrition side effects. Constipation with opioids cannot be overstated. It's a very, very common complication. I'm sure you've heard a lot about opioids over the last few years, and it's a subject that's not going away. In nursing and the medical field, they are extremely effective, but they also come with significant risks. Anyway, that's all we've got for you this Pain Slides. I'll see you in the next chapter.